Darren LUON, clinical oncology pharmacist at Yale New Haven Health in Connecticut, will now deliver our Operational Excellence presentation sponsored by Bayer. This month's Operational Excellence presentation is on sequencing from Nexavar to Stivarga in HCC. Darren.
So thanks for the introduction, Stephen. I just wanted to go into, since I have a little less than 10 minutes now, so going into reviewing HCC or hepatocellular carcinoma. So just reminding us that HCCs, they're a really highly lethal group of cancers. This is the most common type being hepatocellular carcinoma. The SEERS database this year has estimated that there will be about 42,000 new diagnoses of liver cancer and intrahepatic bile duct cancer, so things like cholangiocarcinomas in the US, along with 31,000 deaths. The key statistic here is that this group of diseases is going to be the fastest rising cause of cancer-related deaths in the United States. And it's also, if you look at the overall data, looking at worldwide data, it's the fourth leading cause of cancer-related deaths worldwide. Next slide, please. I wanted to present a summary of the current NCCN guidelines for the management of metastatic HCC. Here we have organized it into whether it's recommended as first line versus subsequent therapy, as well as the NCCN categorization in terms of the strength of the recommendation, category 1 being the strongest with regards to evidence. Now, in the history of the treatment of HCC, there were essentially no therapies that existed or were FDA approved at all for patients with this disease at all until the first drug was approved in 2008. That medication was sorafenib. Afterwards, there was almost 10-year lull where there were no agents approved for patients who had failed sorafenib, unfortunately. However, within the past 2 or 3 years, we've seen an amazing surge of new data leading to the recommendations that you can see here. In the remainder of this presentation, we'll briefly touch upon sorafenib, and we'll be focusing on the first agent that was ever approved for patients with HCC who had progressed on sorafenib, and that was regorafenib. The decision for which of these agents to use once patients progress on sorafenib should really be individualized on a patient-specific basis. But we won't go over that because that's beyond the scope of this presentation. Now, sorafenib, again, this is the first agent ever approved for advanced stage HCC. This is what we call an oral multi-tyrosine kinase inhibitor, or TKI. Specifically, sorafenib targets RAF signaling, vascular endothelial growth factor, platelet-derived growth factor, and KIT. These various targets have a number of functions, but the essential result of blocking these cellular pathways is the inhibition of angiogenesis, as well as having direct anti-proliferative effects on tumor cells. Next slide, please. I wanted to show you all the landmark SHARP trial very briefly. This was a randomized placebo-controlled trial that randomly assigned 602 patients with advanced HCC to receive sorafenib versus placebo. The primary endpoint was overall survival, and this was significantly longer in the patients receiving sorafenib. This was 10.7 months versus 7.9 months. This led to the FDA approval of sorafenib for HCC and its use as really the primary systemic therapy for years for these patients with advanced HCC. Next slide, please. 8 years later, took 8 years, which is a really long time in oncology, new data finally emerged for a new agent, which is regorafenib. This is a really similar drug to sorafenib in that it's another multi-targeted tyrosine kinase inhibitor. While reviewing this table, it can be seen that there are a lot of similar targets to sorafenib, including VEGF, stromal, and other oncogenic receptor tyrosine kinase that again has the overall anti-angiogenic properties as well as anti-proliferative properties. In addition to this, studies in vivo reported that the drug can inhibit that CSF1R, and this reduces tumor-associated macrophages, a factor implicated in the tumor-specific immune response and in tumor growth overall. Next slide, please. Now, the study that led to the approval of regorafenib in patients with advanced HCC was called the RESOURCE trial. It was published in 2017. It was a randomized, double-blind, placebo-controlled trial that investigated regorafenib versus placebo in patients who had documented disease progression on sorafenib. Importantly, these patients had to have tolerated sorafenib, which they defined as taking at least 400 milligrams per day for 20 of the last 28 days of treatment. In addition, and this may be difficult to find, but in addition, patients had to have relatively preserved hepatic function, Child-Pugh class A. Obviously, patients were excluded if they had permanently discontinued sorafenib due to toxicity and if they had ever received any other type of systemic therapy for HCC. They dose regorafenib at the standard dose, which is 160 milligrams once daily for 3 out of every 4 week cycles. Next slide, please. Quickly going through the results, here's the survival curve that demonstrates the primary endpoint, overall survival. After a median follow-up of 7 months, median overall survival was about 10.6 months in the regorafenib arm versus 7.8 months in the placebo arm, which was statistically significant. Next slide, please. Regorafenib demonstrated a reduction in the risk of progression or death with a 3.4-month progression-free survival versus 1.5 months with placebo. Additionally, regorafenib was superior to placebo in all of the efficacy endpoints, such as overall response, disease control rate, time to progression, as you can see here. One of the other important key endpoints was the time from start of sorafenib to death in the resource trial. They looked at this between the two groups, and it was 26 months for patients who got regorafenib versus only 19.2 months in patients receiving placebo. The side effects of regorafenib were generally, as expected. Medications that target VEGF have a very common spectrum of adverse effects. They commonly experience things like hypertension, fatigue, and more rare complications such as bleeding, delayed wound healing, and gastrointestinal perforation. Given that regorafenib targets a number of different targets, it does have other significant adverse effects. And this includes things like hand-foot syndrome, diarrhea, mucositis, and very rarely severe hepatotoxicity. I've listed out some of the more significant toxicities that were described in the resource trial as well as other trials that had studied regorafenib as well. Next slide, please. Given this positive data, the FDA has approved regorafenib for the treatment of patients with advanced HCC previously treated with sorafenib. It's important to identify patients who would be candidates for treatment. So ideally, this means that there are patients who have tolerated sorafenib well, given that these two drugs share many of the same adverse effects. Additionally, patients should have relatively preserved hepatic function as well as performance status based on ECOG or Karnofsky. Next slide, please. So when identifying a patient who may be a candidate for regorafenib, one of the advantageous resources that we have available are our specialty pharmacy services. Now, these are patients who are really good candidates because, for example, our patients who are on regorafenib commonly have these prescriptions sent to our specialty pharmacies. We use either our own specialty pharmacy or pharmacies recommended by their insurance companies. These have a number of advantages that really include having a higher familiarity with these rarely used medications, and as a result, better able to provide counseling and ongoing education as these patients receive therapy. They also are able to help with the financial toxicities of these medications, perhaps referring patients to financial counselors or medication assistance programs. There's an extensive list of specialty pharmacies around the country, and Bayer has helpfully listed many of them in the link provided here on this slide. Next slide, please. Specialty pharmacists and providers caring for patients taking regorafenib should be familiar with the adverse effects that we have already discussed and how to monitor for them. A lot of institutions have their own monitoring parameters, but I have summarized general recommendations in this table. Monitoring liver function closely when patients start therapy due to the rare possibility of hepatotoxicity, monitoring WBCs, hemoglobin hematocrit, platelets for the risk of myelosuppression, and also closely monitoring for any development of hypertension during therapy. Patients are also closely assessed for the development of any hand-foot syndrome, bleeding, or any of these other serious adverse effects that are listed here in the slide. One of the vital things that patients must also be monitored for is adherence, since remember that this is an oral medication. Next slide, please. If patients do develop toxicities while on regorafenib, typically dose modifications or temporarily holding the medication are sufficient to manage these adverse effects. If dose modifications are done, doses are typically reduced in 40 milligram increments. Remember, these tablets are in 40 milligram tablets anyways, with the lowest recommended dose being 80 milligrams. Some of the other important pearls, making sure that patients are taking regorafenib with water and a low-fat containing meal at about the same time each day. If patients do forget to take their medication, they can take it as soon as they remember, unless it's within 12 hours until their next dose. Next slide, please. And then finally, for my last slide, I just wanted to provide a summary of a lot of the great resources that are available to these patients getting regorafenib. Bayer offers what's called the REACH program, which provides nurse counselors for any medication questions, as well as educational materials. They also offer financial access counselors who can help with benefit verification. For privately insured patients, there is a $0 copay program that can assist with high copays, and the link is here. Finally, a lot of specialty pharmacies, including my specialty pharmacy, has the ability to refer patients for patient assistance programs for any patients who do qualify, perhaps those who are uninsured or underinsured. And they can qualify for up to 12 months of free drugs. Just to give a small success story, for example, like my specialty pharmacy works very closely with a number of pharmaceutical companies in getting free drug for patients, and they managed to save well over $12 million in the past year in getting free drug for patients. So it's a very helpful program. And then next slide, please. And with that, that actually concludes me going as fast as I can, and I would be happy to answer any questions at this time.
Great, Darren. Thank you. So as always, we'll open it up for questions. The Q&A box or chat box, feel free to utilize the raise hand function as well. So we'll give that just a few seconds. And I do want to mention, Darren, you did provide a great slide regarding resources. As always, NCODA, our financial assistance tab available on our website, has great financial assistance links for both Nexavar and Stivarga. Again, that's on the NCODA website under the financial assistance tab. So we'll give it a few minutes, Darren. Looks like we got a question. The question reads, are you using the ramp-up recommendations in the PI?
The ramp-up recommendations in the PI. Typically, so with our patients with colorectal cancer, so those the ramp-up recommendations with colorectal cancer, and this is honestly in my practice setting where we use regorafenib a lot more commonly. That's probably one reason is because colorectal cancer is more common. And that ramp-up, I believe, is 80 milligrams once daily, escalated weekly to the goal. In those patients, absolutely yes. We have typically used that, and typically my attendings will actually stay at the lower doses a lot of the time. With HCC, I can't honestly say we have a huge amount of experience yet with using the ramp up. We have one primary oncologist who deals with most of our HCCs, and I've seen her do a little bit of both, depending on the performance status of the patient in question. This is, I think, where our practice can be somewhat of an art rather than a science, because we haven't really forced our oncologists to do the same thing for every patient. I hope that answers your question.
Thanks, Darren. And for our members out there, can you briefly summarize in terms of identifying the patient, some of the, again, some of the clinical pearls that you would look for identifying someone who you think would be a candidate for this sequencing?
Absolutely. So, for the most part, especially with our current practice settings, most of the patients with advanced HCC, they're going to start with sorafenib. I don't really have many patients on lenvatinib. There's not a lot of clinical experience in this indication as of yet. Once patients progress on this, there are a lot of questions on where you can go next. One option, obviously, there's a little dust data at this point for this, but there are the checkpoint inhibitors, which have shown a lot of promise in other disease states, such as melanoma, RCC, and a few others. However, there is a substantial population of patients who may not be appropriate candidates for those drugs. For example, patients with rheumatologic diseases, just other autoimmune diseases at baseline. Those are patients who would probably be a bad idea to use a checkpoint inhibitor right away. And so a lot of these patients are the ones, again, those who tolerated sorafenib well, have relatively preserved hepatic function. These are going to be the perfect patients to get some of these second-line TKIs, especially regorafenib.
Great, Darren. Thank you again. And as always, we will be fielding questions throughout the remainder of the webinar. So if you do have a question, again, feel free to enter it in the chat box or Q&A box, and we can get that question. If not, by the end of this webinar, we can definitely get your questions to any presenter that you ask based on, in this case for Darren. But Darren, thank you so much again. The presentation was very great.
Thank you.